right. Well, welcome and thank you all for joining us for our second webinar of the week for Home Parenteral Nutrition Awareness Week, sponsored by Emerita, titled From Prescription to Infusion, Unpacking How Home Parenteral Nutrition Gets to You. And today we'll also be continuing our webinar contest. For all those attending live, be sure to stay on until the end for a chance to win some awesome Oley merch. At the end of the webinar, we'll be spinning the wheel and we'll be announcing a winner. Just a couple of housekeeping items before we get started. This is a webinar format presentation, meaning attendee cameras and microphones will be disabled and turned off. You'll only be able to see and hear the presenters. While we will not be utilizing the chat or raise your hand feature, you can use the Q&A function, which is available in the toolbar at the bottom of your screen or top, depending on how your view is or if you're joining from mobile or computer. If you have any questions throughout the presentation, you can utilize that Q&A feature. And our presenters will be answering questions not only at the end of the presentation, but throughout. So no need to save your questions for the end. You can use that Q&A feature throughout the presentation. This webinar, like the rest of our events and virtual offerings, will be recorded and will be made available on our website at oley.org/HPN and oley.org/webinars. As always, the information provided during this presentation is for educational purposes only, and it's not intended as medical advice. Before we get started, I want to learn a little bit about you all. Can you kick off the first question, John and Melissa? All right. So who are you? Are you a patient, caregiver, healthcare provider, or are you an industry partner? I love it. I love the diversity. We've got patients, partners, caregivers, a lot of healthcare providers today. And next up, we want to know where you're calling in from. Can you kick off that poll question, John and Melissa? Virginia, Florida, Utah, Atlanta, North Carolina, Pittsburgh, Washington. I love to see it. And it's a little chillier up north than it is here in Florida. Awesome. All right. And we'll be asking more of these interactive questions throughout the presentation. So be sure to keep a lookout on your screens for those question prompts throughout Amy and Jessica's presentation. To get us started, please allow me to introduce our two speakers today. Amy Braglia-Tarpey is a registered dietitian and certified nutrition support clinician and previously earned board certification in renal nutrition. She received her bachelor's degree from the University of Arizona and Master of Science degree in nutritional science from California State University in Long Beach. Amy started her career managing nutrition care and chronic kidney disease and contributing to nutrition research. She then transitioned to progressive leadership roles in infusion care, leading home parenteral and enteral nutrition programs, and working to improve the experience of both consumers and clinicians. Between her extensive experience with chronic kidney disease and home parenteral and enteral nutrition, Amy has developed a passion for quality of life and access to care. She enjoys sharing her expertise through publications, speaking engagements, and collaborative projects. Amy is currently the Director of Nutrition Product Line for Emerita Specialty Infusion. And secondly, Jessica Youngman earned her Bachelor of Science degree in dietetics from James Madison University and completed her internship at Johns Hopkins Bayview Medical Center in Baltimore. She has gained extensive experience working in hospital settings and spent some time in long-term care. Jessica particularly enjoys the challenge of managing complex care parenteral nutrition patients, which has become a key focus of her career. Over 15 years ago, she discovered her passion for home infusion, a field she continues to embrace. In 2018, she collaborated with the Georgetown small bowel transplant team in Washington, D.C., deepening her expertise in GI conditions before returning to her true calling in home infusion. She has a deep enthusiasm for PN and is always eager to learn and share more about it. Since 2020, Jessica has served on the Baspen board as the director of industry, where she thrives on building relationships with professionals in the fields. And without further ado, I'll turn it over to Jessica and Amy.
Hey, thank you, Kaylee. Thanks so much. Okay, let's get started. So Amy and I are so excited to be here today to give you a behind the scenes look at this incredibly complex world of home parenteral nutrition. Whether you're a patient, a caregiver, or a healthcare provider, we hope this session will help you to better understand all of the coordinated efforts in place that ensure safe and timely nutrition support at home. Our objectives today include reviewing the progression of an HPN prescription, review who is on your care team, what you can expect from your home infusion provider or HIP, and what they may ask of you. We'll also touch on what a safe and effective transition to a new home infusion provider will be. I'm kind of saying you as we're talking to patients and caregivers, but really we're talking to everybody. And we want this session to be engaging and interactive. It's, kind of a dry topic. So please do ask questions in Q&A as we go, and we'll try our best to answer throughout the presentation. Next slide. So I'm sure you've noticed that when you or your loved one is admitted to the hospital, there are a lot of people coming in and out of that room. And this is just a list of a few of those people that are specifically working on parenteral nutrition. There's, of course, the prescriber that says you need PN, then the dietitian and pharmacist that determine the formula. You have the nurse that actually administers and hooks up, takes down the TPN or PN. And then you have the social worker or case manager, or just anybody who's discharge planning that when you need HPN, they're going to help coordinate that. Now, for our first polling question, John, if you can pull this up, please. When you're in the hospital, when should discharge planning start? Should it start before you're even admitted to the hospital, on the day of admission, on the day of discharge, or after you get home from the hospital? We'll give you a little bit of time to answer that. Okay, responses are coming in. You guys are very good students. So far, we have on the day of admission winning with 81%. And yes, in an ideal world, discharge planning should start on the very day of admission. So as soon as you enter the hospital, the team is already planning when you're going to leave. And I know it sounds kind of bad, right? Like they're ready to kick you out as soon as you get there. But truly, it is an important piece for anyone who is hospitalized. Planning a complex hospital discharge, especially for HPN, can have so many elements to it. So it's just really important to start that coordination as early as possible. Now, the reality of discharge planning is much more variable. As a home infusion provider, there are times that, we may know about a patient weeks before they're actually ready for discharge, but sometimes it's just a few days before. And then there are times when it's like the day of, they're ready for discharge today, we got to get them out. There's also, just side note, there's also individuals that actually start HPN in the home and are not actually admitted to the hospital. The process we discussed today, it really does apply to everyone. Also, it applies to patients who are already on HPN that are maybe readmitted to the hospital. It's certainly helpful to know ahead of time before a patient is discharged to be able to fully assess the needs of that patient, especially before they start home infusion. And we're going to get into those details of what goes on with planning a start of care, but just a few things we look at straight away. Is it a pediatric patient that maybe would require an experienced home health agency? Is it maybe the first time that a patient is going home on PN? Before they start at home, while they're still in the hospital, could the patient and caregiver start the education process early? So that way they can get more familiar with the IV line or the therapy. Can they practice flushing or maybe learn the importance of sterile technique? And especially for our readmitted or rehospitalized patients, looking at, has the clinical condition changed? Are there new events that maybe need to be taken into consideration before they come home again? So I often compare starting a patient on home PN to aligning the planets. There's a lot of coordination that occurs, and all of these planets here, they're essentially tasks that need to be completed, and they're all complex and really within themselves have multiple tasks. Our administrative tasks, this is where the referral is submitted to the home infusion provider. Benefit verification happens here. Then we have our clinical review, a dietitian, a pharmacist, really looking at at each patient, reviewing their diagnosis, past medical history, lab work, PN formula if they are on it, medication list. We have our nursing team, identifying, okay, is it going to be an agency nurse, or do we have a nurse with our home infusion company that we're going to set them up with? They're going to confirm the type of IV catheter here that the patient has. Finalizing that prescription. This is going to include, we have to actually get the approval from the prescriber. Are we going to get it verbally, or are we going to get it signed off on? Then we have to actually prepare it. This is where we, compound it in our clean rooms, get it ready, ship it. How are we going to deliver it? Are we going to send it by courier same day? Or maybe because of the location of the pharmacy relative to the patient's home or hospital, maybe they have to ship it by UPS or FedEx. All these things to consider. And then finally, you have the nurse visit. This is where the PN is actually hooked up. Patient and caregivers are taught how to administer everything. And sometimes this may entail multiple visits just to ensure that everyone is capable, comfortable, they're ready to do this on their own. This is a big deal. It's really complex and it's not easy. So sometimes multiple visits are required. And some of these tasks can occur simultaneously. For example, you often have a team completing the administrative task at the same time as a team is doing the clinical review. At the same time, a team is maybe identifying nursing support. But some of these tasks can't happen without the other. So, of course, a prescription shouldn't be finalized unless that clinical review has been completed. And obviously, you can't prepare, mix, and deliver the PN without that prescription. And then the nurse visit is pointless without the delivery of those medications. So each of these steps are vital in ensuring that safe and successful HPN experience for our patients. One side note, the size of the planet here does not indicate its importance in the process, okay? Every step is equally important. Okay, can we get our next polling question, John? Now, all of these steps I just described in this aligning the planets, how long do you think they take from start to finish? This is so much fun to watch the responses come in as they come. Okay. So far we have 4% at 3 hours, 8% say 6, 16% say 12 hours. 2 days is the top at 41%, and 33% say other. Well, I hate to break it to you, but there's no right answer. Sorry. Trick question here. I will say there have been a few like select times when it seemed like those planets aligned beautifully. And, I saw a referral get through in record time, not 3 hours. But there are often times when it's like one of those planets just isn't lining up with the rest of them. It could be insurance authorization, maybe a piece of clinical documentation that we need, maybe a signed order, um, or abnormal lab work. But any one of those items or planets, if you will, being out of alignment could cause a delay. But I will say from the time the referral is received, that clock is ticking for home infusion providers. And we really want the plan to continue to move forward, especially because we want to ensure a safe and timely transition to the home and initiation of PN. Do we have any questions in the Q&A so far? Let's see. Oh, I think we're good. Okay. So now can we get our word cloud up, John? What's the first word that comes to mind when you hear the phrase health insurance? Type it in, and you can type in more than one response. Ugh, I love that. Okay. High costs, unclear, stress, frustrating, expensive. This is kind of heartbreaking, actually, because I feel every one of them. I do. Oh, I'm sorry. I'm sorry, friends. Waste of time. Oh, goodness, nightmare. Yeah, I know. It's hard. And I'm sorry. I'm sorry. We can go to the next slide, Amy. Home infusion providers have an intake or admissions team they're going to complete benefit verification. And this is usually the first step and can involve most, if not all of the things that I included in my little cloud here. From the type of insurance, whether it's Medicare or commercial payer, is there a secondary insurance, a supplemental plan? Is there a drug benefit plan? And then you have the plans that require authorization or proof of medical necessity or adjudication. And then there's Medicare and meeting very specific criteria. And what about the copay and the deductible and the out-of-pocket maximum? All like, I know my head spins when I think about all of this, and I'm sure it shows me that, the first our word cloud initially that, it's all very overwhelming, right? Yeah, it's hard. So, rely on your home infusion providers, on their intake teams, admissions teams, whatever they call it at their companies. But, they're the experts in this. They can answer questions and get answers for you. Really anyone starting on home infusion therapy, whether it is HPN or not, you should always hear from your company beforehand, before starting care, to review that coverage, patient responsibility, copays. The big thing, especially if you are a patient or caregiver, please be sure you are picking up the phone or calling back, especially when you are close to start of care, so that way it doesn't get delayed. Before I do go on to clinical review, I thought I may just answer a few pre-questions we had that were more related to insurance. They did seem more related to Medicare specifically, but I'm going to answer just in general. One of the questions was, can you describe the documentation needed for insurance coverage? And really, that is going to depend on the plan. Some plans do follow Medicare guideline if it isn't Medicare. Others may have their own criteria. So if you are a referring provider, reach out to your home infusion provider that you're working with so that way they can find out for you. Sometimes we also don't even know until we submit for authorization, so it can be challenging. But really, ultimately, like the medical record should just really tell the story already and be consistent to support the case for HPN. And that will help to get it approved if they do require documentation. Another question was, what is a long and indefinite duration? Medicare now considers this verbiage to be acceptable to fulfill that permanence requirement. However, I will say that some home infusion providers may have their own comfort level with that. They may actually want a more specific time frame documented in the medical record. And the other, kind of tying back to the last question, the clinical picture should really match. It should tell the story of that long and indefinite duration statement. The other question was, what if the need for PN is just 2 weeks while, for example, an esophageal perforation heals, but not longer? It is going to depend on the payer for that, but Medicare would not consider this to be a permanent need. And then that final question for coverage was, how does being on a diet or enteral nutrition or being NPO impact coverage? For Medicare specifically, it does not directly impact coverage for PN, as Medicare no longer has that bowel rest requirement for certain conditions. So I hope that answers those questions for you. Okay. Clinical review. So this is a vital step for all new patients and also those current HPN patients that may have been readmitted. You know, managing PN in the hospital is quite different from the home, and it can be really helpful to have a savvy HPN clinician review the formula, med list, and clinical situation, so that way we can translate this to the home. Some plans may require medical necessity, and kind of tying back to what I talked about just now, whether it is Medicare or some of those commercial plans, as I'm doing my clinical review, if we do require medical necessity or authorization, I'll pull out the pertinent information that will help support the need for HPN. Sometimes, you know, the records we get may be like hundreds of pages long. I think I got one recently that was like 400 pages. And that, you know, that bogs down the system, right? Like if we sent all of that to the insurance company, it might take them a while to review it. So as I'm reviewing, skimming through most of it, but as I'm reviewing it, I'm pulling out those pertinent parts of the medical record that are going to support our case for why this patient needs HPN. So the remarkable thing about HPN, aside from how, you know, it saves lives daily, that it can be individualized for each patient. There are many ingredients that can be added to HPN to enhance or complement the therapy. We have medications, vitamins, minerals that can be added. And then there's therapies that can be used in conjunction with PN, like IV fluids, catheter locks, antibiotics. One thing to keep in mind is that many of these items may also require their own benefit verification. Not all of it, but also it will require the clinical review. So it is helpful to get, you know, a complete medical record, granted maybe not 400 pages beforehand. But this is also where I think that savvy HPN clinician comes in, especially during that clinical review. You know, we can look at a case holistically, make suggestions to the medical team that, you know, could actually make this therapy more successful, more safe for the patient, and more effective, also easier. So one of the most common examples I think of when I see like a medication, or sorry, one of the most common examples I can say is like when a medication is being given to the patient outside of the PN, but I see and I'm like, hey, that's actually compatible in PN. Can we add it? Other times is when like maybe there's a vitamin or a medication that's added to the PN simply because it's a protocol in the hospital, not necessarily because there's a clinical need for it. So in that case, especially if it is something that the patient or caregiver has to add in the home, I may suggest removing it just for ease of use. Ultimately, the goal of the clinical review is really to ensure the safety of the PN formula for the patient.
Thanks, Jessica. And speaking of safety, given that TPN is such a complex medication, it really requires expert nursing care in addition to the expert pharmacy and dietitian work. So, as Jessica discussed earlier, your hospital and prospective home infusion team are managing everything, everywhere, all at once as we're getting ready for discharge. So, as the pharmacist and dietitian work together to make the prescription more home care friendly by doing some of those things that Jessica just talked about, like potentially adding compatible medications or taking something out of the PN that's not required in the home setting, at that same time, nursing coordination is going to kick into high gear. And so, first, it's important to recognize that nursing options are subject to insurance plan networks. And so they can have a limited network of options. So the agency that may be seeing you to do your TPN education, your initial hookup, and then your ongoing care may be subject to, whatever network your insurance is in. Further, insurance does often, most times, require authorization for nursing prior to the first visit. So the team is working behind the scenes with the insurance plan to obtain that authorization for nursing in the home setting. And then we have to think about timing of the nursing visit. So it doesn't make sense to send out a nurse when the PN delivery has not yet arrived, right? Because there'd be nothing to connect. And it doesn't make sense to send out a nurse before you're discharged from the hospital. So we have to think about that timing and coordinate very closely with the hospital for time of discharge. So, for example, many hospitals discharge patients late in the day. And because of that, there may not be a nurse available for an evening visit. So just like most folks, our nurses work fairly regular hours. And while they may be able to go out sometimes, even into the evening hours, oftentimes that's not an option. So in those cases, when a nurse isn't available for an evening visit for a late discharge, a home infusion pharmacy nurse liaison may do some preliminary teaching and connect the TPN to the patient's line in the hospital before they even leave the hospital. That way they can infuse overnight, and then a nurse can go out in the morning when they're available to disconnect the PN if you're cycling, and also finish up the TPN education and do any additional education and monitoring that is needed for that first visit. TPN may also be connected to, you may also connect to your home TPN prior to leaving the hospital if you're on a continuous 24-hour infusion, so that you go home with that already connected and you get your home set up before you even leave the hospital. So that will include a backpack for portability, and your nurse who comes to your bedside to deliver all that and connect the PN will be one of your home infusion pharmacy nurses that will do that and will provide everything you need to get home on PN. So then we have to finalize the prescription. So for TPN, different from a lot of other medications, it may have up to 30 different components in it. So a written formula is really the ideal for home parenteral nutrition, just considering that high number of ingredients that are in it makes it complex and a high risk prescription. In addition to that, there may be a written billing prescription that's required by your insurance, depending on what those requirements are. Now, in the hospital, a TPN formula is stable for 12 to 24 hours, just depending on how the prescription is written. And when we say stable, what we mean is a formula that's one that doesn't chemically change or degrade over a given period of time when it's properly stored. So guidelines for 9-day stability are used in the home setting, meaning that we can ship out that TPN. It's going to be good for at least 7 days refrigerated and then 24 hours out of the refrigerator. And then we have an extra day for leeway. And so that really allows us to deliver a whole week's worth of TPN at one time to the home. But there are some challenges as a result of that. So the dietitian and the pharmacist often have to adjust the discharge prescription from the hospital to ensure that it's stable for 9 days as opposed to just the 24 hours it's needed in the hospital. And that usually involves changing the volumes of the amino acids, the lipids, and the dextrose, or what we call the macronutrients in the solution. However, there may also be components that cannot be compounded in the home TPN, and that will then be added by the patient at home instead. And one of the most common ones is insulin. Now, once the home infusion provider nutrition support team develops that stable prescription, it has to be signed by a prescriber, and it can't be sent out or delivered until that prescription is signed. So that's a really key step as well in terms of the timing. And then speaking of prescribers, did you know that it can be difficult in many places to find a physician who's willing to manage home TPN? So if the ordering hospital physician won't follow at home, your home infusion provider will get to work to find a prescriber who can, and that's often going to be a primary care physician. However, start of care can't occur until we know we have a prescriber on board who's going to consult and sign the ongoing orders. And sometimes your home infusion provider will ask for your help in identifying a trusted physician on your care team who is willing to manage TPN and sign the orders. So next we get to the compounding step, and this is where the magic happens and your individualized PN formula comes together. It's a time-intensive process compared to other medications due to the number of ingredients or components and the systematic order of operations that's required. So a pharmacy tech must enter a clean room where the TPN is prepared, and they have to be fully garbed to prevent contamination, so basically covered from head to toe. The sequence of mixing TPN requires a minimum of 9 steps for custom TPN. Now, for more complex formulas, such as one for an infant or a young child, there will be additional steps to ensure accuracy and stability due to the very small volumes that need to be drawn up. And then also the pump has to be programmed. TPN must be administered at a specific rate in order to avoid potential complications. So a pharmacist must program and then lock the pump for safety. And so I also wanted to just bring to your attention a question that we got from a consumer in advance of the webinar, which is there a way for patients to observe how their home TPN is compounded and everything that goes into making it and getting it to them? And what I would say to that is you can ask your pharmacy if you could come in to observe the compounding process. However, generally speaking, for patient privacy and HIPAA protections, patients usually can't enter the pharmacy sterile compounding and warehouse areas. But it never hurts to ask if there's some situation that can be worked out. And with that, let me just check in to see if we have any other questions that have come in from the audience.
We do have a couple, actually. One of them is more related back to insurance well, maybe not insurance, but how much does a typical TPN bag cost per day? I don't know that there's an answer to that. And partly, I think, we're not going to be able to answer just because it is proprietary information. Our ingredients, we get how much we pay, it depends on our contracts, and everybody's contracts are different. So Amy, do you have anything to add to that? It's a tough question. There's
I
so
would
much
also add it's a
variability.
tough question to answer because costs are always changing as well. And so anytime one component of the TPN, that cost changes for that component, it changes the cost of the overall TPN prescription. And so when you think of how many components are in the prescription, there's a lot of room for variability there. I would say if you are in a situation with your loved one or yourself where you need to understand the self-pay costs, the provider will quote a cost to you at at that point in time.
Yeah, good answer. There is another one. In general, home infusion will fall in the unwritten portion of insurance handbooks. Do you have recommendations about what kinds of questions can be asked to understand insurance coverage for PN, especially as we are in open enrollment periods for a lot of insurance policies? Yeah, this is hard too. I mean, I think definitely want to make sure that the insurance plans have do cover infusion therapies. There are a few select plans where there actually isn't coverage for it. It's not common, but it can happen.
I would add, you want to ask specifically, do they cover the pump and equipment? And do they also cover the formula? I would ask if there's any limitations based on formulary, particularly if you have something unique in your PN. So oftentimes our pediatric patients, or I shouldn't say oftentimes, but occasionally in our pediatric patients, they may require a specialty lipid. So that would be a question to ask. So I would also suggest maybe just having your prescription next to you, like having a bag next to you to look at that has, your TPN in it, so you can ask those questions. It's a difficult one. Yeah.
Mm-hmm. Yeah, but good call out, Amy. Definitely. And there's one more, but I'm going to save that one.
Yes, I think we should. We'll cover that one though. Okay, so once the TPN is ready to go and the pump is programmed, it's on to the warehouse. So each pharmacy will have a large warehouse where all the supplies are kept, and that's also where the bags are packed and put on ice. So first, the warehouse team is going to receive those bags from the pharmacy, and they'll pack them up, cold packed, so that they come to the patient at the right temperature. Then they're going to pick and pack the supplies, which is typically going to come in a separate box, and they'll use a checklist that's been created by the pharmacy. And so that initial checklist is going to be, the supplies that we would send as standards for any new TPN patient. But over time, you may request different supplies. So those would be added to your checklist at times when you refill, and maybe ask for something different depending on, your knowledge of what you need to administer your TPN as time goes on. Your team may also make suggestions for alternative supplies as well that might help you. For example, if we have a child on therapy, we often send a specific type of tubing for the pump that allows for the tubing to not get tangled as much and allows for more mobility. And then after that, we ready the packages for pickup. And then the delivery methods may vary, but typically a first delivery is usually via a courier, so a driver that brings it from the pharmacy directly. And then for the refills, those typically come via a shipping company, but that will vary from provider to provider. And certainly there are unique situations too where we might send out a refill via a courier.
Okay. So we talked briefly earlier about that inpatient care team, but even at home, there's a team of professionals behind you. We have them listed here. One thing, home infusion pharmacy staffing can vary quite a bit from company to company. Some companies or some pharmacies only staff pharmacists and pharmacy techs to manage HPN. Others have that full nutrition support team, including a dietitian, pharmacist, nurse, and a tech, who collaborate with your prescriber to customize your PN prescription. Dietitians and pharmacists may be trained for some of the same tasks, but think about it as the dietitian is more focused on your overall nutritional picture, while the pharmacist focuses on the medication compatibility, formula stability, as Amy was discussing, and actually dispensing the prescription. Really, both are crucial team members in the care of your HPN. If you don't have a dietitian with your home infusion pharmacy, or even if you have a clinic team, then you may want to ask your prescriber to help you find one, especially if you do need help with nutrition recommendations, if you are trying to wean HPN or maybe optimize your oral intake or your tube feeding formulas. For nursing, some patients may have a home health nurse or a nurse through their infusion pharmacy or an infusion center nurse. And there also are some patients who may get trained to care for their own IV catheter, as long as their physician approves, of course, and they have received very, very thorough training, because it is quite a task, an important task. If you have anything to take home or take from this slide, take home that, there really is value in creating relationships with your care team. The importance of ongoing communication with us, it can truly facilitate a successful home infusion experience. So, what you can expect from your home infusion provider. Weekly phone calls prior to delivery to review any changes to your prescription, maybe review your supply needs for that week. A pharmacist may talk about if there is a shortage occurring, which they should inform you if there is one that's affecting your prescription, of course. The pharmacist or tech may ask how many bags of HPN do you have on hand, how many supplies you have on hand. An assessment will also be done to review your clinical status, maybe asking what's your weight. Do you have any fevers, any chills? Are there any signs of fluid retention or dehydration? And this could be done by a pharmacist or a dietitian, sometimes techs. We just ask that you answer the phone or return our phone calls to our phone calls that we've made. We've had to leave messages. Many insurance plans do require patient contact prior to shipping. So, making that contact is really important. So that way the shipment can be scheduled and there are no delays. And then what we ask of you, essentially. The big one, top of the page here, if you're admitted to the hospital, please call us. Call us when you get admitted, if you can, of course, or have a caregiver call, and then call us before you're discharged. Please don't call days after you were discharged. We really need to start that process, that whole planet align process over again, especially that clinical review, just to make sure that your current formula is appropriate. Sometimes when you come out of the hospital, we may need to actually verify that the nursing agency or the nurse that's going to see you is still able to. We may need to do a new benefit verification if you have a new prescription. And all of that does take time. The other thing, call us when you do have any changes to your insurance plan, your address, phone numbers, if you're on any new medications. Also call us if you have questions. If you get something and it looks different, call us. Let's ask. Definitely if you're planning to travel, if you are having any issues with your pump, we want to know about that immediately so we can replace it. I definitely had some patients call me and say, oh, I've been having problems with my pump for a few days now. And, we want to know as soon as possible. We want you to get your infusion. And then, of course, clinical changes. If you haven't, if you're waiting for your phone call from your pharmacist or your dietitian, but you're having some unusual or concerning symptoms, go ahead and call us. If you are starting to retain fluid, or you're seeing your weight fluctuate a lot, if you're having signs of dehydration or blood sugar fluctuations, or if you have a fever, give us a call. Keep in mind, there may be certain symptoms or situations where we are really concerned. And so we may recommend that you go to the emergency room. If we do recommend that, we really, really ask that you go. I will say many of us have been around for a little bit and we've seen some things. Your safety is our number one priority. So if we're asking you to go to the ER, it's because your safety is at risk. The other thing is, if it is actually truly an emergency, like immediate emergency, seek immediate medical care. Don't call me. Don't call the pharmacist or the nurse. Call 911. Okay. Finally, the thing we do ask that you do is to see your TPN prescriber regularly, at least annually, for prescription renewal purposes. Typically, a prescriber will not sign a prescription if they haven't seen a patient within the year. Going to the one question we actually got here is, what is the one thing patients could do to help this process? And I'm sure that refers to the initial process, but really I think for any time you're on infusion therapy. And I do really love this question because I feel, it just shows that you're engaged and you want to help with your care. I think the one thing is just communicate with us. Number one, just communicate, which you can expect from us as well, right? We should be communicating with you, but that's the number one thing. Amy, I don't know, do you have any other thoughts on that?
No, just to wholeheartedly agree with that.
Yeah. Okay, next slide. So it's important to know that your team is here to support you and we want to work together. Just talked about communicating with your team, but this is also the time when we can work together to set goals. Do you have a specific goal that you want to gain weight or lose weight or maintain your weight, or are you just really focused? You want to work on your hydration. Setting those goals together can really help to, if you have a goal and you haven't really shared what it is, and I'm doing one thing with the prescription and doesn't match up with that goal, you're not going to reach that goal, right? So discussing it and coming together is really important. Discussing barriers is really important as well. If there is something that, maybe it's just in your way and you can't, like there's something that you can't maybe get your TPN infused for the whole infusion, or there's something that just makes it more challenging, talk to us about it because we can be creative and come up with solutions to that. The other big thing is like planning travel. In case you didn't know, but you can travel when you're on HPN. And we want you to travel. We want you to see the world and live your best lives. Talk to your physician and your home infusion provider about what may be realistic for you. The great thing is that Oley has a lot of fantastic resources for traveling when you're on nutrition support. But I've had a lot of patients go across the world, and it's so fun for me to see that, my patients can do it. So unfortunately, shortages are a fact of life these days. And there's so many reasons that they happen. And we could probably spend hours just talking about their impact on HPN alone. A few key pieces to know though, home infusion companies often have access to different components and even supplies than hospitals. And this is actually true with or without shortages, but it's not uncommon to have to require changes to the formula, as Amy said, when somebody is coming out of the hospital. But during shortages, this can add a lot, even more complexity and challenge to the situation. Conservation measures may be in effect. This is when companies conserve product by reducing or omitting components when clinically appropriate. A patient may need to try maybe an oral form of an electrolyte or vitamin instead of adding it to the PN. And what this does is it allows providers to conserve the product for the most vulnerable patients, like, for example, pediatric patients. But I want to say this, conservation measures should not stay in effect once a shortage is lifted and supply is back to normal. Okay. It should not stay in. So, for example, if your multivitamin was reduced to maybe 3 days a week, which that's the recommendation. If we have a multivitamin shortage, we reduce it to 3 days a week. Definitely take oral if you can. But once that shortage is over and supply is back to normal, it should go back to 7 days a week. So the one thing with shortages, we do truly ask that you practice patience. Shortages are not easy for anyone. And often we're having to get new prescriptions during that shortage. that would have otherwise not been needed. And it's okay to ask questions about shortages. You can ask how it impacts you and your condition. You can also ask how long it may last. I mean, we may not know the answer right then, but when my patients are engaged in asking those questions, I know I need to provide updates to keep them well informed.
So providing those updates is so important. And so whether it's information about a current shortage or prescription or anything else that's related to your home PN, you have both rights and responsibilities as a caregiver or a patient. So, for example, you have both the right and the responsibility to participate in your plan of care, which is something that Jessica talked about so eloquently earlier. And that really starts at that time of discharge planning and decision making. You also have the right to be treated with respect and dignity. There are also responsibilities involved as a patient or caregiver, and really one of the most important responsibilities is asking those questions if you don't understand something. No one's an expert the first time around, and your home nutrition support team can only help if you ask. So just make sure, as we've reiterated throughout, that you're communicating closely with your team in order to, maintain your part of the responsibility of caring for yourself and hold your team accountable to observing your rights as a patient. Now, these are just a few examples, and if you're not familiar with your rights and responsibilities, ask your provider to share them with you. They should have a written document with all of this on it. Okay, so I want to shift gears for a minute and go back to when you're hospitalized. So you may at points in time in your journey on PN be hospitalized again. And if you're readmitted to the hospital for any reason, whether it's related or unrelated to your PN, you may wonder why your TPN prescription is different. Or maybe they're not giving you TPN at all. And this can be due to a variety of reasons. So there may be a lack of compounding capability or limiting compounding capability. So sometimes there's hospitals will have an outsourced pharmacy that compounds the TPN, or sometimes they'll use multi-chamber bag already prepared TPN. So that may look different from your prescription. The hospital may not have the prescription that your home infusion provider sends out to you on a daily basis. So they may not have visibility to that. So that's one of the reasons it's so important to let your home infusion provider know you're in the hospital, because they can communicate back and forth with the hospital clinicians about your prescription as needed. You may also have metabolic changes due to your illness that require adjustments to your normal PN regimen. So for example, maybe your blood sugars are really elevated when you don't have that problem at home. That could be due to infections. So you may temporarily require changes like a reduction in dextrose in your TPN or addition of insulin to help manage your blood sugars. And then lastly, sometimes there's just in smaller hospitals, there may be a lack of expertise in malnutrition and nutrition support on the part of a physician. And so they may not, start the orders to get your TPN started in the hospital. They may keep you NPO, meaning, they're not providing any nutrition. But regardless of what the reason is, why your TPN is different in the hospital, or if you're not getting your TPN during the hospitalization, you can always ask to see a hospital dietitian ASAP. They are going to be your greatest advocates in getting you fed. And also, if you share the name and contact information for your home infusion provider, the team can provide your current home prescription to the hospital team as well to make sure your hospital regimen is similar if it's appropriate, if not exactly the same, which it can be in some cases. Okay, so lastly, I want to make sure that we address transitions of care. In the current healthcare landscape, it's fairly common to have to switch home infusion providers at some point in your HPN journey. If your insurance network changes, if a pharmacy closes, if you move to a different place, you may experience a transition. And this can be difficult, as you may have come to rely on the relationships that you've built with your pharmacist, with the pharmacy tech, with your dietitian, and with your nurse. And unfortunately, transitions of care are often pushed to completion in a rush when there should be time to ensure a safe plan of care. Transitions can be messy, but you have the right to ask both your current and new provider to support and guide this process. So this is what your home infusion pharmacy usually gets in terms of documentation from the previous pharmacy. And that includes, typically we'll get the current TPN prescription, the current insurance information, and your patient contact information. But this is what your home infusion pharmacy really needs. So the binders on the right are obviously an exaggeration, but on the next slide, we'll go over what's really needed during a transition. So this is what the new home infusion provider needs from the current home infusion provider in order to facilitate a smooth start of care. They're going to need the current TPN prescription, the current lab orders, including the frequency, orders for any other infusions or supplies. They need clinical documentation on why TPN is needed, a prescriber name, fax and phone number, patient contact information, the date the next delivery is needed, food, drug, and material allergies, the current pump you're using for TPN, and the method of administration for other infusions, such as fluids, along with unique supply preferences. So luckily, the Oley Foundation has worked with home infusion providers to develop 2 transition checklists, one to help with what to know as a TPN patient or caregiver, and one to guide the transition process for home infusion providers. And these should be used more often, but many are not aware that they exist. So if you find yourself in a transition, familiarize yourself with the process using these resources from the Oley Foundation, and also share these resources with your current and new home infusion provider, as well as your prescriber care team. So lastly, Jessica and I put together a list of some of the frequently asked questions we receive, but this just really scratches the surface. So as far as special requests go for supplies, typically home infusion providers will try our best to honor requests, but sometimes we don't have availability with suppliers or may not be able to ask something from suppliers. So it's not necessarily like an Amazon where home infusion provider can order anything they can find. But that said, we do have a knowledge of the universe of products and devices out there and may be able to make a recommendation on where to find something you need if we can't supply it. Now for nutrients, your pharmacist and dietitian may need more information before adding specific nutrients to your prescription. For example, a patient once reached out to me asking if we could add more biotin to her TPN prescription because she had heard it could help with thinning hair and thought she might be deficient in the nutrient. Now, what she didn't realize is that there are multiple nutrient deficiencies for which hair thinning may be a symptom. So an experienced nutrition support dietitian can recommend the appropriate labs to evaluate and ensure the underlying symptom is addressed in collaboration with your physician. When it comes to billing, of course, billing can be the most frustrating aspect of our healthcare system. But what I would encourage you to do is not ignore bills. There are payment arrangements that can be made if needed, and your home infusion provider may also be able to guide you to financial assistance resources. So again, it's another time when that line of communication is really important. And as Jessica noted earlier, your home infusion clinician providers will also help you with travel to help you live your best life. So you certainly can travel with PN. Careful advanced planning coordination will help to ensure the most memorable part of your travel is the destination and not the challenges of traveling with PN. So I know we've reached the top of the hour. In conclusion, there are many steps just to begin your journey with home TPN, but you have a whole team behind you. So it's your turn. What else do you want to learn about how PN gets to you? We can open the Q&A if we have time for questions.
So thank you so much, Amy and Jessica, for sharing your time and expertise with us. Since we are running short on time, what we will do is collect all of the questions that we've received so far in the Q&A, and we will send them over to our speakers for response. If you think of any other questions after the presentation, you're more than welcome to email us at info@oley.org. make sure you're following Oley's social media channels and getting our emails. You can sign up at oley.org/join. That way you're receiving updates about our upcoming events, including virtual and in person. To check out the recording of this presentation, you can visit our website at oley.org/webinars, and be sure to check out our HP and Awareness Weeks webpage at oley.org/HPN. And be sure to follow us for events throughout the rest of this week. All events are free to attend. And if you're a clinician, you're more than welcome to get in on the fun and help us spread the word. Thank you again to Emeritus Specialty Infusion for sponsoring, Amy and Jessica for your time. Have a terrific Tuesday or Wednesday. Oh my goodness, everyone.
Thanks everyone for joining.